Thank you very much. The presentation today is the current strategies in SSI prevention. And here are the presentation objectives so that you have something to evaluate at the end. Identify the intrinsic factors that contribute to SSIs. Discuss the significance of SSIs. Discuss how modifiable factors contribute to SSIs. Describe how environmental factors contribute to SSIs. And describe interventions that protect the integrity of the sterile field. So intrinsic factors identify those things that we really don't have any control over in the operating room. These are things that the patients come in with, and sometimes we can identify them before the patient comes in, but usually the patient will arrive with some of these things. They'll be nutritionally compromised due to their own medical problems, or the patient may have had a prolonged hospital stay. This also identifies the patients that are institutionalized. They have time to colonize. Morbid obesity. The morbidly obese patient has tissues that touch and there's always moisture. Plus, morbid obesity contributes to so many other problems for the patient. Diabetes. Now, this is just coming to light. That diabetes is a contributor to infections. Cigarette smoking. There is a surgeon in Washington State who is at the Madigan Army Hospital who will not operate on a patient who is a cigarette smoker unless they've been smoke-free for a year. Systemic steroids, that's pretty common knowledge, in the altered immune response. Also, I had the opportunity of working in Seattle with Fred Hutchinson patients and the first bone marrow transplants that were being done in this city. And this was quite a long time ago. And they found that they did a total workup, especially dental, if they had any problems with teeth, because that would contribute to the rejection and contribute to an infection. And coronary artery plaque is really making the news now, that it is an inflammatory process, and that patients on aspirin reduce that inflammation and had fewer problems. A bladder infection can infect an orthopedic surgery. Way back in the early 1970s, I was doing surgery in Seattle. I was a new nurse, and we had a patient that we did back surgery on, and that became infected, and the surgeon was very upset because we used to use such stringent aseptic technique, and they found that patient cultured with a bladder infection after surgery, and that was the same organism. Nares colonization is becoming great news now. It is such a simple way for total hip patients to help total hip patients to reduce their infection rates. So hemorrhoids or an ingrown toenail that the surgeon doesn't know about can increase the infection rate. You have your skin integrity. You will operate on your patient the way they come if this is an emergency surgery. Trauma patients have all sorts of contamination due to their trauma. Institutionalized patients will have skin breakdown, plus they're colonized. The frail patient, and as our population ages and the baby boomers are becoming more popular than ever, and chronic antibiotic use, and this is being addressed by the CDC also. Personal hygiene. I don't know what the culture is like where you are practicing, but personal hygiene varies with different cultures. where I am in the Seattle area, we're on the Pacific Rim, but there are also lots of subcultures of migrants. We have a great homeless population here. I think it's only larger in Portland, Oregon. And the homeless population does not have adequate bathing facilities or access to bathing facilities. And we treat them when they come to our door. And patients have their own indigenous flora. Then there are those contributing medical factors. A patient who's anemic, their respiratory health, poor glycemic control. Now, if a patient comes to your door as an emergency patient, and I know in the Seattle area, sugar was not checked when a patient came in for same-day surgery, a quick in and out surgery. And there are some institutions I have found in this country by talking with other nurses that every patient that comes even to same-day surgery is checked for what their glycemic index is. This is important because stress will bring out latent glycemic, lack of control, DVT prophylaxis, their cardiac status, or morbid obesity. This is coming up again now in the literature. So what's its significance? For a patient, it's a life-changing event. If I go to the hospital and have a total knee and come out with an infection, this will totally change my outlook on life and my life. The immobility of treating that infection, the staying in the hospital, it's a huge, huge event. It increases patient morbidity and mortality. And it's bad news for hospitals. The stay in the hospital is increased from 7 to 11 days longer than those without SSIs. And hospitals lose $26 billion to $33 billion every year due to HIAs. And this is just one statistic. When I looked at the literature, these statistics are all over the place. The high estimate is 25,000 per infection, and it's about 10 billion annually. So according to a CDC report, in January 9th in 2017, 700,000 patients get hospital-acquired infections. 90,000 are from MRSA, and 99,000 result in deaths. If I go to the hospital for a total knee, I don't think I want to exit that way. These are the estimates of increase in hospital stays. And you have to remember, these are averages. That's a lot of money. And Medicare does not reimburse for a readmission within 30 days of discharge. The hospital must absorb the cost. Not only is it difficult for the patient, but hospitals, their margins of being able to give the care that they need and pay for their equipment, for their nursing care, they're finding it very, very difficult to make it. And Medicare will not pay for what could be prevented. This is just in our recent history here. In 2015, President Obama signed the bill authorizing OSHA to increase penalties. In 1970, the fine was $1,000. In 2015, it was increased from $7,000 to $10,000. This was implemented only not quite 2 years ago. And the fines keep going up. And failure to abate is $12,675 per day. This is a big hit for hospitals. Plus, there's patient dissatisfaction. I know how dissatisfied I'd be. Are your patients, and all of your patients in your facilities are given satisfaction surveys. Not a patient gets out of there without filling one out. And the second-party payers are also reimbursing according to patient satisfaction. I had a cabin in the mountains near Mount Rainier, and when I was up there last year, I saw one of my neighbors, and his name was Pete. And I said, Pete, you're walking with a walker. What happened? And he said, oh, I had a total knee. And I said, where did you go? And this was in Pierce County. And the big hub for Pierce County patients is in Tacoma, Washington. And I said, did you go to one of the hospitals in Tacoma? He said, no, I went to Swedish Hospital in Ballard. And Ballard is a small community. It used to be a fishing community. And I said, Ballard, did you know a doctor there or anything? He said, no. I looked them up on the internet, and they had the lowest infection rate. So patient in this rural community was looking online to see where he should go. He did not know any of the doctors, and he did not know any of the anesthesia or any of the staff. He went there because their infection rate was the lowest. So the only thing we can do anything about is the modifiable factors, things that we can change. So these are the SCIP measures that we operate by. We know that preoperative bathing or a skin wash, and there are all sorts of products available for that. Appropriate hair removal. We don't use razors anymore because they contributed to infection. Timely and appropriate antibiotics 30 minutes before, not while the incision is being made and the tourniquet is up. Temperature control. We know that when our patients are kept warm, they have lower infection rates. And monitoring patients' glucose. This is something that was brand new to me 1 year ago in Boston at AORN's Expo. And the author of the 7S bundle to prevent SSIs, Maureen Spencer, she has her own website, and she did all of this research. And while I was listening to her and watching her presentation, I learned so much new. She asked, is your operating room safe? Who cleans it? Is this an agency that has been outsourced by your institution? I remember a long time ago, I used to teach the staff, the auxiliary staff, to clean the operating room. I understood microbiology. The people that are cleaning your rooms, do they understand the microbiology behind what they're doing? Or does anyone watch them or check up on what they're doing? The second S is screen. Are you screening your patients for those risk factors? Not every physician will. I know when I was practicing at a small 3-bed hospital, or a three operating room hospital, Seattle General, that was absorbed by a big hospital a long time ago. Our orthopedic surgeon didn't see the patient that was going to have the emergency hip operation on Saturday until the day before. This physician wasn't screening for all of the risk factors. We didn't know all of the risk factors then, and a certain number of them became infected. Now we know that we need our patients to shower with chlorhexidine the night before and the morning of. And the one thing Maureen emphasizes, do you send them home with a little sample bottle of chlorhexidine, or do you have to give them a great big bottle? Or do you count on them for going to the pharmacy and purchasing it themselves? or do you give it to them and give them instructions on how to bathe with it? Skin prep. Are you prepping the skin with alcohol-based antiseptics, iodophor or CHG? Alcohol is one of the facilitators on making that skin prep work. Are you irrigating the patients, irrigating the tissues prior to closure using CHG? This was a big eye-opener because we were told that by the manufacturer that CHG was not to be used. Apparently it can be, but CHG is under a lot of controversy right now. So this may be changing. She also identified sutures. Are you closing tissues with antimicrobial sutures? This was a new one too for me. Said, wow, everybody ought to know about this or at least hear about it. Or in skin closure, are you sealing the incision or covering it with an antimicrobial dressing? I have heard from other attendees of this presentation that they don't like sealing the incision. And I know I did a lot of pediatrics and we always seal those hernia incisions to protect them from the diaper area. Hand hygiene. This is another big one, and it's in AORN's guidelines. A standardized procedure for hand washing should be followed. Hand wash should be performed upon arrival. And I know I've worked in a facility in Idaho where everybody, including the support staff, did that 10-minute scrub and cleaned their fingernails every morning. Wearing gloves will not replace hand hygiene. Now it's a myth that it does. The studies have found 15 to 17% rate of colonization after glove removal. And there is a communication between organisms to pass on resistance. And that was a big study that Maureen Spencer indicated that an organism that was resistant to certain antibiotics could actually pass through the cell membrane their DNA of resistance into an organism that was susceptible to that organism. I recommend very highly checking out her website. Gel products may be used, but only after the initial scrub, and those are your gel antibiotics that you probably carry in your purse. No artificial nails. Nail polish is okay still according to AORN guidelines. And hand contamination of your anesthesia provider is also a risk factor. So skin preps, this is a big one. Soap and water is okay. It does clean the skin. It takes off contamination. Alcohol denatures a microorganism. It shrivels it right up, takes the fluid out of it. Chlorhexidine disrupts the cell membrane. And chlorhexidine and alcohol inactivates the bacteria, and iodine and iodophores disrupt the cell membrane. And then there's still the quaternary ammonium compounds. Excuse me. So soap and water is a friction. And people with their surgical attire, then there's a new guideline under review right now at AORN because you should have clean scrubs upon entering the OR suites and cover them when leaving. However, there are lots of institutions, even here in Seattle, the facility lets people wear their scrubs home. And it was my observation that people would put on new scrubs when they were leaving the operating room and wearing them home. And I asked why this was going on. And I was told that, well, we don't want to bring home all of the stuff we've encountered here at the hospital. Yet they would wear them back in the next day and go right to the operating room. Hair needs to be covered. Personal head covers need to cover facial hair too. Home laundered scrubs. A lot of hospitals pay a lot of, or save a lot of money by letting you take home your scrubs and launder them yourself. But they're being worn home in cars, public transportation, or you're wearing your scrubs home in a car where you've transported your dog to the vet. This is where I have a real problem. And personal items and jewelry being hanging and containing contamination. There has also been some studies done by a friend of mine, James Dubinsky, who's with CCI, and he has done some studies with his partner, Dr. Boyle, and there are still studies ongoing with the Joint Commission, and they're studying colon resections and hysterectomies, and to seeing the infection rate difference on those, because they're contaminated cases or clean contaminated cases, and their infection rate is higher. So they're studying those. And then Stavisky found out that there are hospital characteristics where there are more infections. It's a lower infection rate in a non-teaching hospital. And they're studying why right now. There's a lower infection rate in non-magnet hospitals. I wonder why. They're investigating that, but these are just the results of the research they've done so far. And there is a lower SSI rate in higher number of employees who are CNORs, CRNFAs, C-SPAN, and longer RN tenure. And this is, I think, the result they were looking for to justify certification, but it's interesting what is coming out of these studies. Then we have environmental factors. You could have the dirty operating room. A multidisciplinary team should establish your cleaning procedures and their frequencies and evaluate the cleaning between cases. And I've already touched on this, but who teaches the people that clean the room and who monitors them? And when is your terminal cleaning done? And surgical instruments, the cleaning and sterilization of instruments. And I don't want to tell you what SPD was called in the institution that I worked in. However, they hired people at minimum wage and gave them minimal instruction on cleaning these instruments. They didn't even know what they were used for, and we didn't know how they were cutting corners or how much they understood what they're doing. This is becoming another topic of interest, and there is a lot more being done by Amy to instruct people, to certify people that are working in the instrument department. And who inspects those instruments? Are they pre-soaked? Has the organic matter been removed before it's dried on, which really increases the bioburden? Then you have your airflow in the operating room. Who monitors those air exchanges and humidity levels in your operating room? The standards were developed by OSHA, and I was working in a facility where we got there and the engineer came, and it was a small 25-bed critical access hospital in a very rural area, and an engineer came up and he was checking the humidity, and he said, "You can't operate today. The humidity's too high." And we waited until the humidity went down. So in places this does work, and in your larger facilities, I know that there's a department that makes sure they let you know. They record it, but do they report to you? And your traffic control, airborne contaminants and microbial levels in the environment, they're directly proportional to the number of people coming and going in your room. And AORN's recommended practices for traffic patterns is worth reading and following. I know sometimes you can't control your traffic. So this is what this is all about too. AORN has been doing research, and in 2014, it changed its recommended practice to read when there's an unanticipated delay or during periods of increased activity, a sterile field that's been prepared and will not immediately be used may be covered with a sterile drape. This was the deviation, and I know in 2015 and in years since, I have been running into nurses that say, no, you can't cover the back table. Well, this has been changed, and you can cover it. And this is the study that's cited in the AORN guideline. It was an independent study, and 45 sterile trays were placed in a positive airflow OR and randomly assigned as followed. Number one, they were opened and left uncovered in a locked operating room. So there was no traffic. They were opened and left uncovered in an operating room with single person traffic in and out every 10 minutes. And opened and immediately covered with a sterile surgical towel and left in a locked operating room. Cultures of the trays were taken immediately after they were opened and every 30 minutes during the exposure period. So this was a controlled study. And this is what the findings were. After 30 minutes of time with traffic, 4% were contaminated. However, take a look at the next column, no traffic, 4% were contaminated. The ones that were covered with a towel, 0%. After 60 minutes, with traffic and no traffic, 15%. Covered, no cultures. After 120 minutes, traffic or no traffic, still the same amount, 22%. Still 0% for the covered table. After 4 hours, with traffic or no traffic, 30% was contaminated. Covered were still 0. So sterile instruments can be contaminated in as little as 30 minutes. And this is right from the picture, right from the article that's cited in AORN guidelines. There's also another study in 1996, an orthopedic independent study. They studied 41 total joint replacements. 27 were hip and 14 were knee to study the effectiveness of covering the instruments. The instruments were covered during periods of increased activity like positioning or transferring. There was a 28-fold reduction of instrument contamination. So new ventilation systems have also been shown to increase OR contamination. Their particle counts at the table with laminar airflow resulted in a significant 4-fold increase in counts compared to the table without laminar airflow. How does this happen? And here it is. This is the journal if you want to find the article. And this is how it becomes contaminated, because your table is out to the perimeter of the room. Or if you want to keep it clean while the patient is being positioned or people are coming in or before you're draping the patient. But look at the way the airflow, it goes down to the table and it goes back up and it comes back down on the sides of the room. And your air intake is usually at the bottom of the room, if you look in the corners. So what can we do with this knowledge to change things? You have to know what your current practices are. Facilities policy and procedure keep them current with new AORN recommendations. So this is our gold standard. And how do you comply with these recommendations? Not everyone complies 100%. It depends on what works for your facility. And do you keep statistics? Do you keep records of what you're doing? Is there a change? So you can tell by what I've told you that new research is necessary. And just recently, AORN sent out a survey regarding covering the back table and if whether or not it is attended. And it is beginning to look at this because I know when I worked in Boston and learned how to be a scrub tech at the Boston Lying In, which is now part of Brigham, it's Brigham and Women's, we used to set up for a C-section, cover the table so that we were ready to go with an emergency section in 2 minutes. Everything was counted, everything was done, and there was a method on how it was covered. And I know in very small hospitals where the team is not living in the hospital at night or you don't have a team, these are covered, that the practice differed from what the guideline was because otherwise it just wouldn't work. And so AORN is revisiting this recommendation, the recommendation of this guideline, and it's soon going to be out for public comment about covering the table, how long should it be covered, how it could be covered. And more research has been done in our industry sector, duplicating the prior research and extending the time periods in the study to 12 and 24 hours. And we'll be waiting to see what happens with the use of all of this new information to see how AORN is going to change its guideline. And that's due out sometime this year. The public comment period will be. So and there are changes in practice. I remember when we always used to have a closure table for a bowel procedure, and we would move it aside, and we would have this clean, sterile table for closing a bowel case or closing a hysterectomy case. And we got away from that, saying, oh no, we don't need to do this anymore. And now it's gone full circle and it's going back to that. And a sterile Mayo is set up and moved aside to make it ready for closure so it didn't extend the period of time of the case. So it can be a Mayo stand or it could be a table. And is it covered? To keep it clean, because if it's sitting there and people are walking by within a 2 or 3 hour period of time, it's definitely contaminated. And C-section readiness, that's another question. Are you in compliance with the current recommendations, and does your facility conduct process improvement to see what they're doing is working? So what can we do? We need to protect that sterile field, and now we know how we can do that. When there's an unanticipated delay or during periods of increased activity, a sterile field that's been prepared and will not immediately be used may be covered with a sterile drape. Preparations for hip nailing as an emergency. I remember when I was a new nurse in the 70s, and the patient had come from a nursing home. They were in the hospital in traction, stabilized for surgery, and being wheeled into the room with all the doors open. And none of the sheets had been changed under this patient because that patient was in such severe pain. And then we'd have to get him out of that bed and put him up on the fracture table to be able to do the surgery. And as an emergency surgery, the surgery tech had to break scrub and help. How else could you manage with just 3 people? And you could just see the dead skin and the dust flying in the air. And this was contaminating the table. When I was in the heart room at a big major hospital in Seattle, we had a second table for a heart valve replacement. And this was a few years ago, so I'm not sure what the practice is now, since I'm not practicing there now. But we had a second table for the heart valve replacement, and it would be all set up by the nurse who was scrubbed, and it would be moved to the back of the room. Well, we know now, with the knowledge that we've got, that that table was contaminated because it was several hours before the valve was ready, was to be placed in. Or anterior posterior approach to spine surgery. Recently, I was working up at another facility in Seattle, and there was one surgeon who would do the anterior approach to the spine surgery and set the cages or whatever he was doing. And then we would completely take down the room after we had closed. The patient would be turned over. He would go to his office and do a microdisc surgery and come back because we completely opened a room for the posterior approach. We completely moved everything out of the room from the anterior approach and did the posterior approach for the spine surgery. So that was one way of handling that problem. Very time consuming. So if you can cover that back table to help keep it clean, it needs to be, certain criteria have to be met. It needs to be applied by the sterile person after the field is set up and the counting is completed. So everything's done so it can be covered. It needs to cover the whole table. And this is the tricky part. It has to be removed without sterile field compromise by an unsterile person. When it's removed, then the sterile field is ready for draping in the incision. So no time is wasted. I have permission from AORN to use their picture from their guideline. This is a 2-sheet method of covering the table, and it needs to have a large cuff put on there, and it has to have 2 sheets with the second cuff as that person is applying it that will completely cover the first cuff. So there has to be no exposure of that first cuff. And as you can see, a majority of that sheet is draping over the table, so gravity may pull that down. It may slip if the table is bumped or if the table is moved. And when it's removed, the first cuff is grasped just in the manner that it was put on the table, but in the reverse, lifted up and removed, and then the person needs to walk to the other side or a second person to remove that drape. So what are your available products for doing this? There is the 2-sheet method with large enough for cuffs and to cover the entire table. There are new products now being developed by our industry partner to fill this need. And I know AORN is evaluating those now. Our whole goal here is to reduce the infections and to improve the patient outcomes. That's why we practice as operating room nurses. Any questions are encouraged, and thank you very much for attending this webinar.
Okay, thank you so much, Melanie. Yes, we have got some questions. Do the current recommendations call for identifying intrinsic factors by PCP or by surgeons at a pre-op visit?
As far as I know, these are not stated in any of the guidelines. I'm sure that they are identified by the primary care physician or practitioner when the patient comes to see them. However, we have no control over those patients that enter on an emergency basis or don't follow their primary care providers' recommendations, and we don't know how informed the primary care providers are.
Okay. In general, overall, how does the US compare to other countries in regards to reported HIISs?
I'm sorry to tell you that I don't have that information, and I'm sure it's available somewhere, maybe with the CDC. I know that the United States lags in some medical procedures because of the FDA, and we have a different type of reporting system. But that would be a very interesting thing to explore. So thank you very much for that question.
Okay, and another one that's coming. Do you know when the new AORN guidelines will be released?
Oh, if only I had a crystal ball. They are working on them now at AORN, and they are receiving all sorts of information, and they are really going over the whole guideline. I know that one of the areas where they're looking for information and looking for evidence-based research is, does the table have to be monitored when it is covered? Because that is part of their guideline now, but there seems to be a lacking of evidence-based research available unless they have found some since I have last talked with them.
Okay,
also, when this guideline is getting ready, watch your peri-op insider, because AORN will make it available for, I believe it's a time period of about a month, for public comment on that guideline before it is finalized and then published for next year's 2019's guidelines. So you will, as an independent practitioner of being a perioperative nurse, be able to address that guideline and be able to comment on it.
Okay, and another question that's coming. Is the repeat violations fine for hospitals based on a per case basis or total of all violations?
Thank you, that's a good question. It is based on the per case basis and for all violations. From what I read in the research, all of these are reportable, and the hospitals voluntarily report. However, they are lumped together with all HIAs, all hospital-acquired infections, not just SSIs. And if the rate does not change and they don't change their practices, those are the ones that are considered repeat violators. So I'd have to do a little more reading and looking at that particular statement. So thank you for that question.
Okay, and following on, do you think the AORN recommended practices will be changes to include immediate covering or draping of sterile fields?
That's a good question. We're hoping that it will, because that's what the research has shown, that this table will be set up and covered before there's any activity in the room. But as you can see, it's not just covering the table, it's a whole host of other areas of the patient's condition that contribute to these SSIs. But the things that we can do something about as a perioperative nurse is not just covering the table. That's just not the one thing that's going to fix this problem. It's going to be making sure everyone complies with the dress codes and the changing and having clean scrubs and not wearing your eye protection from a MRSA case around your neck and contaminating your scrub gown. It needs to have everyone in the perioperative arena to have an excellent surgical conscience.
Okay, and we've got some more questions that have actually come in. How many facilities are using the day of surgery pre-op nasal iodine swab and oral rinse on all surgery patients to reduce the risk of SSI?
That's a good question, and I can't tell you that because there's not been any, any questions for a central reporting agency for that. But I know I've been following that, and even in small rural acute care or hospitals where I worked 3 years ago, they were using the nasal swab. It's such a very inexpensive way of helping keep the patient from colonizing themselves.
Okay, and what does AORN say about having fluids on a table that will be covered?
I don't know. That I can't tell you. I think that would be a good question to ask during the period of public comment. When you have fluids on a table, they're usually used for irrigation, and they should be immediately poured and be immediately warm, so that you're not cooling the patient, because the temperature of the patient is one of the factors of increasing the surgical site infection. But I'm not sure that none of those studies that I've read had used any fluids.